So there's only 8 slides for you. Can everybody hear me?
Yes, we can.
Perfect. Thank you very much. So this lady is a Gravida 3 Para 1. She had an SVD in the year 2000, so 23 years ago, and a miscarriage in 2022. I believe the gestation was less than 10 weeks at the time. She was an unbooked pregnancy until 32 plus 6. I'm not quite sure why. It's not strongly documented, but she came into triage with some abdominal pain, and then that was her first appointment with anything midwifery or obstetric related. So yeah, and she was in the country for this time as well. 34 plus 3, she attended with query Schrom and abdominal pain with suspected gastroenteritis. So she was admitted to our antenatal ward, which is where she had her booking appointment. And then multiple CTGs didn't meet criteria at that time, but they were all the STBs were above 4. And then eventually, I think she stayed with us for about 2 days and got some treatment, some antibiotics, and was sort of given lots of fluids, and then she was discharged after 2 days. GBS was detected at her 32-week speculum, which was obviously os closed. So just bear that one in mind. And then she had multiple DNAs after her admission to antenatal ward. And yeah, she also declined blood products, and there was quite a lot of safeguarding input here as well. 36 plus 3, she had a normal ultrasound scan where they showed that her placenta was anterior high, and normal fetal growth, Lycor and Dopplers. So she came in on the 22nd of the month. She was 37 plus 0 at the time. She was examined at 9:30 in the morning. Her cervix was 2 centimeters dilated and the presenting part was at -2. And following on from this, she was actually discharged and sent home. The person that did this CTG has noted that they were present when this looks like a possible deceleration here, and it was in fact some loss of contact, possibly maternal pulse. I think the maternal pulse in triage was actually also around sort of 80 to 90, so that would account for that loss of contact. But otherwise, we can see clearly that we're contracting sort of maybe 1 to 2 in 10 here, and baseline here looks to be around 135. Obviously, Dawes-Redman was not used, which is great because she was contracting, but overall, her overall clinical picture was good and she was encouraged to go home. Normally, depending on the sort of level of antenatal care that women have had, sometimes we do, if they've been unbooked and they've had not a lot of midwifery or obstetric care, we do tend to keep them in once they have sort of presented in labour. But this lady was sort of well, all of her observations, urinalysis and whatnot were all completely normal. So she was considered to be fit for discharge home and then to come back in when her contractions are more regular and whatnot. Any concerns, anybody?
It's not a concern, Cara. It is just a question. You said on the previous slide, attended with Schrom. Was she Schrom or not?
Sorry, should have made that a lot more clear. Query Schrom.
Oh, so she wasn't Schrom then?
She wasn't Schrom. No, definitely not. We definitely would have kept her in if she had Schrom at 34 weeks, I think, for a little bit longer than that. But no, Rom plus was completely negative. So her waters haven't broken at all.
And we are GBS positive from the 34 weeks attendance that with the speculum.
Yeah, absolutely. And she was counselled about this as well, so that if she obviously did Schrom at home when she was in active labour or when she was labouring at all, that she would need to come in so that we could give her the treatment for antibiotics. And this is also very well documented as well. So well done to the midwives that were caring for this woman, because I think sometimes GBS is something that we've missed, a couple of times. It's not something that we've missed very frequently at all, but it's definitely something that we may not pay as much attention to if it's not sort of flagged up. If we're not aware of GBS, or anybody that might not be aware of our sort of GBS protocol in labour, we start IV benzyl penicillin from the time they are either in active labour or from when their membranes rupture. So if women are sort of still os closed but GBS positive, they're recommended admission for IV antibiotic treatment on our antenatal ward. And also we should be seeing those bright yellow stickers on the front of the notes for all of the women that do have GBS, just so that we can draw as much attention to it as possible so that we know we can provide them with the correct treatment. So do look out for that in practice if it's not something that you're familiar with. But yeah, absolutely, we must always start sort of treatment from either SHROM or from active labour. Yeah, 3 grams is our main loading dose, and then we give 1.5 grams as a maintenance dose every 4 hours thereafter until the baby's born. So just make sure we've got that prescribed by our doctors and that we're keeping on top of her IV antibiotic protocol. Perfect. So she went home and then she returned back to us. This is still the same day. This is 5:30 p.m. now, and at 17:30 she was examined, found to be 4 centimeters dilated. Presenting part was actually -3, and that was determined by this midwife. So she was admitted straight away to labour ward. I think there was slight delay in getting her a bed just due to the acuity on the unit at the time. But yeah, as soon as she was round there, she was then cannulated, and her loading dose of benzylpenicillin was given at 7 p.m. Just to sort of say, so our baseline is still similar from the previous, but what I also want to draw attention to here is the fact that her contractions have very much picked up. The Toco's picking up reasonably well for this woman as well. But I want to know what you think of the CTG here.
Hi. So the variability is decreased, and there's some LOC, so we don't know if that those are decelerations or what's going on, as well as the contractions. It's like 4 in 10 or almost 5.
Yeah, nearly in some
So there's
cases.
no
If there's,
resting tone.
can I just ask if there's anybody that's in the lobby at the moment for the presentation? Can we please make sure to let them in? I've just had a text message saying, "Let me in." So whoever's
I did let them in. Yeah.
okay, perfect. Thank you. Lovely. Yeah, absolutely, Darshni. We have got reduced variability here. For a woman that's in active labour, we would sort of normally say that that a period of reduced variability is normal up until sort of 40 to 50 minutes. What you're seeing at the moment is like 45 to 50 minutes, so definitely reduced. Also, I feel like I don't know if anybody else thought this when they looked at the CTG, but when we put a maternal pulse oximeter on, or sometimes when we're picking up maternal pulse, it looks a little bit similar to this in the fact that the lines themselves look more like dots all collectively together as opposed to a bolder line. I don't know if anybody noticed that, but that was just something that sort of picked up from me. And often when we've got maternal pulse oximeter on, the maternal pulse line looks a lot like this, almost like there's little dots everywhere, whereas the fetal heart rate's normally kind of a straightish line or much bolder. But definitely the fetal heart rate, this is fetal heart rate, as maternal pulse was palpated. I think it was still 80 or 90 at this point. But we don't have it. All of the observations that were done on this woman were actually included in my presentation, but it's just maternal pulse that was documented manually in the sort of free text, if you like. But yeah, absolutely, we've got sort of 4 to 5 contractions in some areas of on this CTG, and we've got reduced variability. So plan-wise moving forward, does anybody have any recommendations as to what they would do? So to those that have also just joined us, this lady is Gravida 3 Para 1, previous SPD in the year 2000, and she's GBS positive at 37 weeks exactly. And she's just been discovered to be 4 centimeters dilated, and this is her initial CTG on labour ward. So yeah, what do we think in terms of plan of care here? What would we do if we were concerned about this CTG?
And just to add for the newcomers is that she is no antenatal except late booking at 32 weeks and GBS at 34 weeks.
Yeah, and just the one scan, I believe, which was at 36 weeks, which was all completely normal. So plan? Mr. Naguib, what would you do?
I personally would go and examine and do some fetal scalp stimulation. I would see where is the like what is the situation with the membranes? Has it ruptured? Has it not?
Mm-hmm.
Uh, and see my the response to that. And if there is some like change in the pattern, I would be more reassured. If not, then I would be more inclined, like to treat it like as abnormal and proceed for delivery. But I would first see what is the response. Where are we from 4 centimeter to what? Where is the head? What is the bulging membrane or not? And like I grasp all the clinical scenario and also do some assessment of how big is the baby by manual examination, like overall assessment.
Yeah, absolutely. If we ever have a situation whereby we're concerned about the variability, fetal scalp stimulation is definitely going to, show us something reassuring, or hopefully show us something reassuring for sure. Cool. So we'll move on to the next slide. This
Sorry,
lady was
Cara,
moved.
to ask you,
No, go
because
for
I
it.
came in late.
That's okay.
Do we have any antenatal CTG apart from this one, or anything to tell us what was the baseline, the one that is normal for this baby? So I know it's a 37-weeker, but do we know that the baby's baseline is 140 already, kind of from
So
previously?
yeah, so she came in the morning, Maya, at 9:30 and was found to be 2 centimeters, but because she was considered somewhat low risk, she was sent home. But this was her previous CTG in the morning.
So actually, the baseline is stable.
Yeah.
Okay, cool. That's more reassuring, isn't it?
Yeah, for sure.
Okay, perfect. Thank you.
Perfect. So we'll continue. This lady was moved to a left lateral position. I think this was one of our sort of conservative measures, but she was really uncomfortable. So she was moved back to a semi-recumbent position. At 9:33 in the morning, the doctors did a 19:33 p.m. Apologies. Doctors recommended an ARM to determine the liquor colour. And then at 19:53, an ARM was attempted but failed due to maternal discomfort. The midwife in charge at this point was present to discuss the need for ARM due to potential fetal compromise. But the sort of key learning I wanted to bring out from this case, and what I'd really, really like to hear the opinions of, is, for example, you've got a CTG that you're concerned about. You've got a woman that's contracting in sometimes sort of 4 to 5 contractions within a 10-minute period, and you're suspecting fetal compromise. As much as knowing that there's meconium gives you a better insight into the overall clinical picture, why would we do an ARM that we know can increase contractions, can stimulate progression in labour, and can actually cause additional stress on the fetus if we've already got a stressed baby? And also, my question is, whether or not this woman has meconium stained liquor, is that going to change what we are going to do for this baby and for this mother?
I mean, Cara, there is no black and white. So there is,
No.
you can't like draw line and say that's wrong and that's not wrong. Everything has its advantage and disadvantage. In this situation, you are in a position, you are squeezed in the corner, more or less. You are 4 centimeter with a CTG that is you can't fully say abnormal, but at the same time, you are not happy. You are not reassured. So there is decreased variability. You want to grasp more information. Doing an ARM in this situation, I know might increase the contraction, might make you have more of a prolonged deceleration. But at this point of time, as well, as they say in one of the sayings, you have the enemy behind you and the sea in front of you. There is no what to do. There is that you need to do something. You have done a scalp stimulation with the and you are trying to do something. It's not succeeding or it's not giving you, but you don't want to section her for no reason. So ARM with meconium would sometimes gives me more acumen to jump and say, you know what, meconium 4 centimeter with abnormal CTG. I am more of, yeah, let's go, rather than clear liquor and so on. So in addition, with all this contraction, if you see bleeding coming, like you are more of the impression that there is some sort of abruption.
Mm.
So I, as much as I want to condemn it, I feel like I have no options here, and I am playing with, as we said before, I'm playing with this baby kind of chess, and I have no option except moving my queen, even if I lose it. Yeah.
Mm. So my question is then, if, for example, they did do an ARM and there was meconium present, would that mean that you'd be more inclined to go to theatre than if the liquor was, say, clear?
Yes.
Would we be happier to sit on it if the liquor was clear as opposed to mech?
I would say yes. With the mech, you don't only risk the hypoxia, you risk the meconium aspiration as well. So a kind of a double whammy. I'm not saying like a blanket statement, but at the same time, with ARM, you are really scratching this baby's head. It is a combination of things. It is things that completes for me the pieces missing in the picture. As much as I don't want to do it, yes, and I hate to do it when there is so much contraction and the CTG is, but I have nothing else to do.
Yeah, that's really interesting. It's this is one of the things I wanted to sort of discuss from this was, we there's a lot of things, like you say, Mr. Naguib, when you're playing chess, and as you always say, obstetrics is very much an art. For me, I just my initial impression when I was looking at this was, okay, we've got an already possible hypoxia CTG. If we ARM her, then is the likelihood that actually it's going to get worse? Yes, that could actually end up with us proceeding to delivery quicker and therefore shortening the length of time that this baby spends in this environment that could be quite toxic. But at the same time,
Exactly.
yeah, and
Yeah.
I totally understand that, but I just kind of thought, interesting. But also what I just want to highlight was, if you look at 1953, that's when the first VE was done by the case midwife when attempting to do an ARM, and there was no fetal response to this ARM or this attempt at an ARM. So that's another thing to take into consideration before then the midwife in charge came in to discuss the sort of higher need to do it.
So if I am trying to ARM and the attempt is unsuccessful or failed, I consider that meconium until proved otherwise.
Yeah.
If I am the person and I'm sure I have done my best of the best, I think that is thick meconium behind the baby.
Yeah, absolutely. Perfect. We'll move on to the next.
I would
Sorry.
love to hear also the opinions of my colleagues sitting with us. Like we
Yeah,
have,
me too.
yeah. So okay, maybe they don't have different opinions, so we can go
Maybe.
ahead.
Or they're being shy this evening. Yeah. Perfect. Okay, so this is your next segment. So we've now had, sorry, let me go back quickly. We've now had reduced variability since 1830. So this has now been 2 hours of reduced variability. This patient is now increasingly more uncomfortable. She's in quite a lot of pain. And she's removing the TOCO or the transducer, sorry, from her abdomen because she's finding it very uncomfortable. She's also declining, moving into a different position so that we can get better monitoring. So just again, take that into consideration as well. Obviously, we want to make sure our patients are very comfortable. And if they are declining anything, then there's nothing that we can really do other than give them all of the information so that they can make an informed choice. At this point, the team had discussed doing an in and out catheter with this woman, but this was also stopped due to the mum's discomfort before it was successful. And then they encouraged her to go out to the toilet to pass urine. She went out to the toilet at around 20:44, although unfortunately we didn't measure it. So we don't really know how much there was, and there's no report as to how much there possibly was either. Just as a sort of another key message to come from this case as well, can I please encourage everybody that when we have women that are anybody that's in labour, something I think we need to seriously improve on is our bladder care and also our hydration. Making sure that women are drinking oral fluids, but as well as obviously if you need to fluid resuscitate them in any kind of way, but measuring the urine output is also going to give us a lot of information about the overall clinical picture. If they have blood-stained urine, this could be a sign of possible obstructed labour. And also measuring it's going to help us to know how well her bladder's getting on with the fact that the uterus is right next door to it and could be possibly affecting it too. So if we can just take that as a key message from this, trying to make sure we're getting a fluid balance and we're accurately recording it would be really, really vital in helping us get the information for the overall clinical picture in this case.
Tara, may I ask you?
Of course.
Does this lady have a recent set of observation? Because obviously also she's GBS and there's a little bit of uterine irritability. I know I'm always jumping into choreo, but do we have any sets of obs that would tell us that anything about any possibility of infection?
We don't, unfortunately, Maya.
Not
So-
even a pulse, no?
No, the pulse was taken about 2 hours ago. It was around 8. I think it was between 80 and 90. But no other obs were taken. I think my brain goes to human factors here and thinks, okay, we're concerned for the CTG. We're thinking, okay, what we're going to do about the CTG? What we're going to do about the CTG? And we kind of put maternal observations and maternal well-being kind of to the back of our heads at this point. That's my pure assumption. I obviously wasn't there present, but yeah, I'm assuming that's what happened here.
And it's also kind of like handover time, and it's always a very critical time when
Yeah.
you're overlapping. So like 8 o'clock, it's always a very dangerous time.
Oh yeah, for sure. Absolutely. So yeah, human factors do play quite a big part here too. But yeah, the thing that's concerning me also is the fact that we've had 2 hours now of reduced variability. Obviously, our patient is declining our monitoring and our recommendations, which there's nothing that we can sort of do. But she's gone out to the toilet, and then what happens is she shroms mech, as if we didn't think that was going to happen. The doctors do a ward round, and the consultant comes and does a VE at 9:10. due to the fact we've now spent nearly 3 hours with significantly reduced variability. I don't know whether or not these were decelerations or maternal pulse, because unfortunately there was no maternal pulse that was recorded here. But based off of what it was about 3 hours ago, I would assume that this is possibly maternal, but we have absolutely no way of knowing. The consultant does an examination at 2110, finds her to be 5 centimetres, and they're recommending a caesarean section in which the patient is declining. And this is unfortunately the end of the case, because I have no theatre CTG for this lady. I don't think one was done. As she was being wheeled round to theatre, she voiced an urge to push as they were transferring. And then she pretty much had an SVD in theatre immediately once they'd got there. Now, there's no way of knowing that we could have gone from 5 to fully dilated in the space of sort of 25 minutes. But yeah, I just wanted to know what people's thoughts were, really.
You could go from 5 to fully, especially if she's a multip, isn't she?
She is, yeah, 23
multip
years
and
ago, multip, but yeah.
Oh, 23 years ago.
Yeah.
Okay, but she, I mean, I'm hoping, you know, we didn't get the second VE wrong, but she could go from 5 to fully, especially that we've mobilized her. But there was, you know, this CTG, I agree with Mr. Nagy saying choreo or not choreo, meconium throughout. But I think the fact that she's a multip has saved the day, to be honest.
Yeah, for sure. The one thing that I go on.
No, go on, Car.
No, go.
You know, what I'm thinking as well is what Maya is saying here, that being multiple saved the day. And also, I would say the shrom saved the day. I mean, the shrom made, you know, in a way, the head to come down and do some dilatation. I know it is not usual, not unusual, but not usual to go from 5 to fully in space of 5-10 minutes. But it happens a lot of time. Yes, I agree, and that's why I'm saying the VE and the information that the VE gives you is crucial. And sometimes it is 4 centimeter, yes, but the head is +1. And and you know it. Once you break this water or something, this head will fall out. So the VE is crucial, and the ARM in some situations is crucial. Sometimes is dreadful. Sometimes it's crucial. So yeah, I mean, but the quick progress tells me that this baby will be slightly shocked.
Yeah. The other thing I wanted to add just from this is, now that we've got the benefit of hindsight, and we can clearly see that now the fact that she shrom and progressed to fully dilated so quickly, the likelihood is that at her previously the membranes were bulging, or the baby's moved and the membranes are now bulging. But if we'd have done an ARM the hour before, when we'd sort of originally planned to, we could have actually, this is purely with the benefit of hindsight, but we could have actually had quite a probably a nice normal delivery in the room, as opposed to the rushness of moving around to theatre to deliver her via possible caesarean section. So this woman's ended up having an SVD in theatre. There's nothing that we would have done differently, I don't think, in terms of, you know, we've spent 3 hours with reduced variability. The likelihood is that she was going to need some form of intervention because we had fetal concerns. But if we had done that ARM an hour or so ago, we would have avoided the stress of having to move quite promptly to theatre and then ended up having a baby in there.
But Cara, remember that 10 years ago, this was the practice. We used to ARM to know if there's meconium or to know if there's APH, and it was kind of like the regular practice. And then we moved away from it because we know that it kind of stresses the baby more. But then now you are reflecting on this retrospectively, but it could have been also the opposite scenario, and you could have ARM'd and then the baby would have had a prolonged deceleration and you would have ended up in Cat 1. So we really can't really say. We only know that over the years we've decided that ARMing someone just to know the color of the water is going to add more stress. As Mr. Naguib said, the CTG was indicative enough to say that there is meconium. You know, we know from certain patterns, even though there's no guideline to say a CTG that looks like this equals mech, but you can tell that this is, you know, a stress and the aftermath of the stress. So I think there's no right and wrong, but we know that we could have also like ARM'd and it wouldn't be the same outcome.
No.
So we can't really guarantee, and this is what you're trying to say. It's like, yeah, we could have ARM'd in the room and had a nice delivery. Now I think there's no harm done, but it could have been also like a cat one.
Yeah, absolutely. This is why I said hindsight is that wonderful thing.
Exactly. So there's no right and wrong. We know
Sorry.
that, you know, you can stress the baby, and it's not always that you can have a precipitate labor, kind of like a very quick progress. So we have to go by, I think, what we know and what we kind of like see on a daily basis, and exceptions are exceptions.
I think
That's
someone
it.
was going to say something.
I think the woman declined, didn't she, earlier?
Yeah,
So it's no, we couldn't have false sick.
no, absolutely, exactly. And this is another thing, another sort of key message. If we've given given women all the information and we've recommended certain things to support her through her labour and she declines it, then there's nothing we can do. But yeah, lots of sort of key things. Also, I just wanted to sort of mention again, meconium in terms of presence is obviously can be very much a sign of stress, specifically more so for a baby that's, you know, she's 37 weeks. If we were sort of seeing this as a post-term fetus, I think the likelihood is we'd be slightly less concerned about it than one that's at 37 weeks, because we've clearly got a baby here that's showing us signs of distress before, well, probably since she's become into active labour. So we've already got a compromised baby at quite an early gestation. It's just another thing to sort of add from that as well.
I would say also, Cara, there is unsaid things that we have as interactions with the patient. Uh, a patient that suddenly takes off the TOCO and the CTG and I don't know what, you start acting slightly, how do I say, it's defensively. You start thinking she will decline everything that you will say. You start, you know, it is not the easiest of the situation, you know, like, and also you mentioned that she doesn't want to have blood products.
Yeah.
Uh, we are human beings at the end of the day. It is not that we are like angels and managing medicine as, you know, like without bias. We are human being is biased, whether it is conscious or unconscious biased. And suddenly you feel like I'm going to not interact. So again, it makes the interaction difficult, I would say. This is what I
Yeah.
always feel.
Yeah, for sure. Although this lady, she declined blood products, I believe it was due to sort of religious reasons, but she never, but not the sort of typical religious reasons that we would account for. And she had no advance directive signed either. She also sort of, I think she didn't decline to sign it, but when the conversation was brought up with her later on about possible like need to save your life, I think she'd decided, okay, yeah, if that was the case, then maybe, but she was very much undecided on it. And didn't have an advance directive, which obviously we 100% need if we do have a woman that's declining blood products, even in a life-saving situation, for sure. Would anybody like to guess the outcome of this baby?
I think normal needed the abgas were low, but the gases were fine. So probably the baby needed some support with breathing, but the gases were fine. Like 7.25, but just the abgas probably 5, 7, 9, something like that. And some support with breathing.
Yep. Anyone else want to have a guess? No? Well, I'll put you out of your misery. This baby had APGARs of 8, 10, and 10, and then had venous gas of 7. I mean, I think that these are very clearly the same because there need to be a difference of 0.03. I would probably say this was venous as opposed to arterial, just due to the highness of it. Venous pH of 7.41, base excess of 1.7, and a lactate of 2.2. The fact that the base excess is so low means it sort of says to me that, okay, this baby was not suffering for a prolonged period of time, despite the fact that that variability was reduced. This baby has some raised respiratory rates, but didn't get neonatal review until I think quite a long period of time afterwards, I think 24 hours later. Born 2995 on the 55th centile, which was pretty much what it was predicted to be. However, at sort of 12 hours, the SBR was very high and above the exchange transfusion line, so needed to be admitted to the neonatal unit for triple phototherapy. I'm not very familiar with sort of a higher, as I've not seen very many pHs that are higher than sort of 7.39 or so. I don't know if there's a link between sort of a higher up pH or anything like that with respiratory distress that I'm aware of, because I mean this could be considered normal, no, but was admitted for triple phototherapy. So the likelihood is the baby had something possibly going on antenatally.
But that wasn't hypoxia for sure.
No.
Yeah, so it wasn't hypoxia. I was suspecting some meconium aspiration though.
Yeah, no, not respiratory distress for this one, which surprised me too. I would have assumed it had some form of respiratory distress, although they did have high respiratory rates, which did then come down. So possible sort of need for additional support, but it wasn't reviewed at the time. But yeah, then the baby needed admission for triple phototherapy. They didn't need a blood transfusion in the end because the phototherapy brought the SBR down. But yeah, I just thought the outcome is kind of different to what we'd expect. Cool. Does anybody have anything that they would like to add?
Yeah, why would baby have blood transfusion though? I don't understand it.
Because of their raised SBR.
Is it not in line with phototherapy?
Sorry, not blood transfusion, exchange transfusion.
Sorry, that's what I meant.
Yeah, it's
Yeah.
different. So blood
Yeah.
transfusion, you're giving blood. Exchange transfusion is different.
Yeah, sorry. That is what I meant. I do know that.
Venus pH was 7.4. All right.
I have never seen a baby with 7.4.
Neither.
Collective.
And yeah, and
I'm
what
thinking
was
this is the mums. Can't be babies.
and what was the size of this baby?
2995 on the 55th centile.
So well done her on her own, doing everything on her own in her country, and
No, she
Yeah.
was in the UK for that whole time.
Oh, so she and she booked at 32 weeks.
Yeah.
Okay, fine.
Perfect. Well, thank you everyone for contributing today.
Thank you very much, Cara. It is a very lovely case and shows us more and more that we know nothing about CTG. So
Please don't say that.
Well,
We were just
the
about to
evidence,
section her, please.
there's little to no evidence to support the CTG's
Yeah.
uses. So, and it's becoming a lot more apparent in some of our most recent cases. So yeah, I don't know. There's going to be something's going to happen at some point soon that says some piece of research is going to turn around and say, stop using them. They're completely useless. And they've got no evidence to support them because they currently really don't, which is just wild. But it's true. So I'm just waiting for that to come out, and then my job will be pretty much null and void.
Is it the new AI, that the one that does the homework? I don't know what it's called. That will read the CTG and just say everything for us, isn't it?
Yeah, exactly. So our job, Mr. Naguib and Maya, it's never,
yeah, yeah. I think
useless.
I think the new thing would be the capsule that has some intelligence that we implant inside when we do ARM. Hopefully,
Yeah.
it will be a nice invention.
Absolutely.
Thank you so much, Cara.
Thank you, everyone.
Tara, I just wanted to say, did you do the new trainees know about the CTG weekly teaching?
Yes, they've all got
Okay.
the link.
They all got the link, so that I
Yeah.
can kind of like encourage them every week to join this meeting, because I can't see any
Absolutely.
of them today unless I'm mistaken.
No, please do encourage them, Maya. That would be
That's
great.
fine.
Thank you,
Okay.
everyone.
All right. Thank you so much, Cara.
Thank
Bye.
Thank
Good
you.
night.
Bye.